Please go ahead. You can start. I'm going to mute everybody.
Sorry, I start again.
Yeah, you can share your slides again.
Chance.
Lovely.
Good evening, everybody. I would like to present my case about meconium aspiration. It will be a all parts of this case. Sorry. It was a newborn male, gestational age 40 weeks, the weight more than 3 kilo, AMGAR score 6-7 scores. This boy was born from first pregnancy and first delivery. Mom had unfortunately distress, and our colleagues used vacuum extraction, and it was a meconium amniotic fluid. But this baby was active baby. He was crying. He had a very nice muscle tone and nice heart rate. But during 15 minutes of his life, he had a respiratory failure. Dolan score 2-3. We started nasal CPAP, but the situation was not good. Dawn scores 5-6, and finally we started to use the invasive mechanical ventilation, and this baby was transferred to neonatal intensive care unit. And our first lung ultrasound we did when this baby had 3 hours of life. When we used the invasive mechanical ventilation with maximum pressure 24 centimeters, and he needed oxygen 0.4. He had acidosis. Unfortunately, we had technical problems with our X-ray machine, and we couldn't do this examination. And we used the lung ultrasound, and we had pathological pictures. It's R1, and we can see a regular pleural line, sliding plus minus, no eye lines, B lines more than 3, and subpleural lung consolidations. It's a R1, a similar situation R2. This region, similar situation R3, plus static bronchograms, and video from left side. It's L1, similar changings, L2, and we have a double point line on this area, and we have signs of atelectasis. And I have a problem with my video, as usually. I'm so sorry.
Don't worry. Just you can restart. Take your time.
Yes.
Just while Dr. Babin Seva's starting, can I just say, can all of you see the beauty of images even using a convex probe? in that the amount of information that we're getting is very nice. The depth, the quality of the images is absolutely beautiful. You have good gain settings, and really, I think what you can clearly see is a very diffuse bilateral involvement with an interstitial B profile, but with very patchy consolidation bilaterally in a setting of a baby who has significant meconium, significant respiratory needs necessitating ventilation.
Mhm. Can you see my presentation?
Yes, please go
Yes.
ahead.
Mhm. Mhm. Next, lung ultrasound we did when this baby had 12 hours of his life. Unfortunately, it was not positive situation, but not so negative, but not so positive. And we, after our lung ultrasound examination, we decided to change our type of ventilation support, and we started high frequency ventilation. No? With and start parameters, it was um, MAP 70 centimeters, frequency 13, amplitude 12, and we started from 100% of oxygen. Why we started this type of ventilation? Because it was the science of Beline's profile in every part of lungs. It's the right one, not so bad like in other parts, but bad. And we understood that this area is very bad. And B-lines more than 3, and subpleural lung consolidation, and signs of atelectasis. It's a right 2, similar video, static bronchograms, compact B-lines.
So I was just going to come in because this is such a beautiful image on the right side that you could
Mm-hmm.
play again. And somebody asked me what static air bronchograms are last time, and I would probably not get any better images. But if you look at this entire region, what you've got is you've got the pleural line, you've got some subpleural consolidations, but if I just rub out, what you've got coming in at the bottom over here are basically static air bronchograms. That's air trapped in an area of consolidation that can't get out. And naturally, with inspiration and expiration, what you can see is that it's relatively constant, does appear, disappear, and you get a little bit more and a little bit less air trapping. So it's appearing and disappearing as dots, as opposed to going in and out as linear profiles. So these are static air bronchograms, whereas if they move in and out, kind of air moving in and out, that's probably because you've got a bronchus that connects to it, which is pushing the air in and out. Then those are called dynamic air bronchograms. And if you look at the differentials for this beautiful case, I mean, at the moment, I can't convincingly say that I've seen a fractal sign anywhere, which would kind of lead me towards infection, though you can get a fractal sign with meconium aspiration as well. I'm also kind of in the situation where I don't really have a lot of dynamic air bronchograms to support my diagnosis at this particular point. So the most common differential for a case like this would be term RDS, would be potentially sepsis, pneumonic infection on consolidation, and really what we would then be kind of thinking of is whether you might have meconium aspiration. So those are the three common differentials. But for me, with the history of meconium and this kind of clinical presentation, the deterioration, the history that the baby's got, This would fit very much with meconium, especially with the patchy nature of the atelectasis. Again, lobar pneumonias and congenital pneumonias will usually be focal, and
Mm-hmm.
this is very diffuse. Please carry on.
Mm-hmm. It's a
So Pialu,
left
which is
side.
Yeah, that's the left side.
Mm-hmm. It's a next left side. L2 and L. Just
Don't worry.
again
Don't worry.
problems.
Don't worry.
I don't know why, but this video. Mhm. And this is the lung ultrasound before high frequency oscillation ventilator. And now I demonstrate our third part after um,
Don't worry.
after 12 hours on high frequency ventilation. I'm so sorry.
It's okay. Don't worry. Don't apologize at all. It happens
Mhm.
all the time. Just for the group again, when you put a baby on more ventilation with meconium or high frequency, the expectation is that if the baby's clinically improving, the FiO2 is coming down, the gases are improving, the mental modeling would suggest that you should start seeing elements of lung aeration. So it'd be very, very interesting to see what we see with this ultrasound. Very important as well to see whether there's improvement or not. But crucially, I think what Dr. Babin Seva has beautifully demonstrated, is the importance of serial lung ultrasound. Please carry on.
Mhm. Mhm. And this lung ultrasound after 24 hours his life, but it was after not 12, maybe 9 hours of high frequency ventilation, but it was a time when we have more light parameters of ventilation. We have a MAP 9 centimeters and FiO2 and oxygen 0.21. Right side. We can see R lines. Still we can see B lines, but not compact B lines. It's R2. Also we can see R lines. We can see R lines between these I lines. So we can see B lines, compact B lines, and also situation of double point criteria.
The lung is better aerated, must say.
Mhm. And R3 also we can see R lines, still B lines but not compact, more than 3 for example in this area.
Yep, I agree.
Mhm.
So especially in R3, what you can see is the appearance of what is double lung points with A lines versus B profile, which is again a sign that there's recruitment of lung, the lungs improving.
Mhm. Mhm.
Very nice.
And left side, L1 R lines, B lines, double point sign, L2.
Very
And
nice.
I am afraid,
Don't worry, don't
but
worry.
we'll try.
I think what you're seeing in these three lung ultrasounds is serial improvement. Your baby's
Mhm.
getting better at this point.
Yes, yes, and I have a fourth, but when we use the non-invasive ventilation, I try to change my presentation. And this baby didn't have signs of inflammation nor any criteria, normal blood, normal CPR, and so we decided that it was a real meconium aspiration in active baby.
Amazing.
Sorry again.
No, don't worry. So for meconium to improve, often what you'll find is that the consolidations can persist up to 4 weeks, often getting better with kind of better aeration, but up to 4 weeks they can persist. Very similar to chest X-ray findings.
But it is another type of probe. It's a situation when this baby had 72 hours of his life. Non-invasive ventilation with maximal pressure 22 and oxygen 21, 3. Another type of probe, it's a handle probe with frequency 9. Right side R1, nice lines, sometimes bell lines like a comet tail, but very nice mirror effect also. No, yeah, very nice bed symbol. R2 again, nice R lines, B lines like a comet tail, sometimes maybe more than 3. For example, in this area, R3, very nice symptom bamboo symptom, and by lines like a comet tail, and nice sliding, very nice plural line, and left side. B lines more than 3 on this area, and this also more than 3, but plural line is nice. L2, it's okay, physiological state, and L3 also is okay, it's okay.
Very nice.
So I'm finished.
Thank you so much. Any questions about that particular case, and in particular, any questions around meconium aspiration, just while we're doing it? So
Yes, Dr. Alok.
yeah,
In this case, we can try one dose of Cervanta.
No. It's not, it's my opinion.
Yeah.
Sorry.
So the challenge of using Cervanta in situations, and Dr. Bhavinseva explained it very nicely when we saw the cases, the cost. So it's quite costly. And I mean, this is a situation where they weren't able to use surfactant, but the babies had a good outcome.
Honestly, we thought about surfactant in this situation. Sometimes we used surfactant with in a very difficult situation when with real meconium aspiration, when we have intubated babies and we have meconium through into oh my god, my English.
Already on high frequency.
A tube, but in this case, we thought about this, but we decided firstly to start the high frequency ventilation because we understand that this baby had a lung edema, and we tried to help his lung to be to have less water, no? And maybe if we don't have success with high frequency ventilation, we decided to use surfactant also, but I'm not sure that it will be helpful for this baby because no, we lost time. It was maybe 40, 45, 48 hours of life, and maybe it's not good time for surfactant. But,
Excellent.
uh, but but finally, maybe we are lucky in this case that we can no, that we have a successful with high frequency ventilation, but without surfactant because really it's no, for us it's very expensive. In this slide, 3 kilo babies for 3 kilos, uh, unfortunately.
So one of the things that I wanted to kind of discuss with everybody about meconium aspiration is the kind of differential diagnosis and how you differentiate this from pneumonia, RDS. It's usually fairly easy to differentiate it from TTN. I think the important thing about both RDS and pneumonia is the presence of consolidations, the presence of an element of atelectasis, which can be seen in all three of these conditions. Now, how do we think about pneumonia as a clinical presentation? Well, so early on, what I would say is widespread bronchopneumonia is possible with group B streptococcal infection. And I mean, I will be showing you some really nice cases that we've seen over the years. But often what you'll find is this quite extensive fractal sign when you have pneumonic consolidation. If it's a lobar pneumonia or a consolidation that's quite large involving a part of the lung, like the right upper lobe or the left upper lobe, and there's PROM, you're thinking whether that might be a congenital pneumonia as the presentation. Patchy bronchopneumonia and meconium aspiration can be quite difficult to differentiate. Now, what I'd say is it's very unlikely if the baby's sick that you wouldn't have started antibiotics. Now, the CRP can go up in both of them, but one of the markers that might help you is a procalcitonin, which often takes time to go up with, again, meconium aspiration, but may be elevated if you have sepsis that's been there antenatally and has caused that kind of clinical presentation in the first 12 to 24 hours of life. It's not cheap. It's an expensive investigation. It costs about 40 pounds versus a CRP, which you do with a panel, which would the entire panel would be 7 pounds. But lung ultrasound wise, I would say the presence of extensive fractal sign, and again, if you have a lot of, I would say, Doppler blood vessels that you see that are quite focal with a very high CRP or a rising CRP that say produces a positive culture, that's gold standard. That'll be mnemonic kind of clinical presentation. Meconium aspiration presents in a very patchy way, but as you saw, the consolidations here they were quite varied. They were small, they were large, there were areas that you've had static air bronchograms. And again, with pneumonia, you'll tend to have dynamic air bronchograms. With RDS, you tend to have a lot of, I would say, white lung appearance, but really with a lot of subpleural consolidations. So again, some of this is going to be clinical correlation, but differentiating all these three features, and it's going to be term RDS because naturally most babies who have meconium aspiration tend to be near term babies. It's very uncommon to find meconium aspiration under 34 weeks unless you've got, again, either listeria or additional infection that's complicating and causing compromise. Do you have any confusion about differentiating these three? Do you have any, or any comments? We've got a very, learned faculty group here, but any comments, your experiences that you'd like to share? Has anybody other than Dr. Babin Seva, have you seen any meconium aspiration lung ultrasound so far? Anybody else? Dr. Surjit, Dr. Ashraf?
Yes, I have a case.
Yes, I saw many.
Okay,
Usually in Meconium it is patchy وموست of them يعني small وscattered on both lung fill, not like pneumonia. يعني pneumonia mainly large consolidation. وتيك تايم sometime الماركر high يعني صار بي ممكن يبقى positive also with Meconium aspiration.
sure.
Yeah.
Lovely. Dr. Surjit, would you like to share your cases?
Yes, yeah, doing it.
God bless you. I'd be very keen to see cases from the others, guys, if you have any. Again, I know that some of you can't share cases for reasons of confidentiality. Again, if you need to have one-on-one sessions that are not recorded, you just want to have one-on-one sessions to discuss your cases, come back to me. I'm very happy to organize sessions with you just to try and improve your image quality. I am going through your logbooks. Naturally, we're kind of at a phase where I think people can make improvements. The benefit of just knowing which machine you're using in your probe and the frequency is really important when you save your cases. So please do just mention that when you save your cases. Dr. Surjit, are you okay? Lovely, beautiful.
Hello,
So
Dr. Alok, can you hear me?
I can hear you. Your screen is visible.
Yeah, this is a lung ultrasound of a preterm 32-weeker baby, 1.7 kg, had severe respiratory distress at birth. So we had to intubate the baby at birth, and ultrasound was done at 3 hours of life. Next. हो नहीं रहा है ना फिर? Yeah.
Very nice.
Yeah, this is R1, and here we can see two intercostal spaces. The batwing sign is seen, and the pleural line is not visible. Can we say, Dr. Alok, like I can't see any pleural line as
So
such.
my only comment is you're really deep into the image. In
Okay.
in this zone, my gut feeling is this is just 2 centimeters, is it?
Yeah, 2.6.
Yeah.
Yeah.
So the challenge with that is what is happening is you're losing the deeper lung and the pleura because you're so magnified, which is quite thick, blurred, and irregular with these subpleural consolidations that I can definitely see. Uh, so if I just compare your right, and I'm just going to use my pen to draw. So
Okay.
yeah, the pleura is definitely visible here. It's thick and blurred. Where it's not visible is here.
Okay.
And really, what you've got is you've got these subpleural consolidations over here that you can see very nicely. Here you've got deeper consolidations, but the pleura is not established because the lung is not aerated. So here you've probably got a little bit more atelectasis. If you zoom out and try to go to about 3.5 to 4 centimeters, you will be able to
Okay.
see this a little bit better. So just my only comment is your depth should go up to minimum 3.5, considering it's a 32 weeker.
Okay.
I'm just trying to work out your frequency here is, you remember what you were using?
No, I
No
don't.
problems.
This done
So
few days back.
it looks as if it's 12. Uh, Again, you're using a sonocyte, aren't you?
Yes, yes.
Yeah. So the sonocyte, you don't have to adjust the focus. You can see the focus is actually
Yeah.
good at all regions. I think my only comments would be get your depth up and try to
Okay.
zoom out a little bit. Really, what I'd like to see is at least at least 3 ribs with 3 intercostal spaces. I can see them, but we're just very superficial. Your next image is much better. So please, we can see your next image. Yeah, very nice.
Yeah, this is part two.
Yeah,
And here, three ribs are seen and three intercostal spaces are seen,
yeah,
and bat wing sign is seen,
yeah.
and the pleural line is discontinuous. Yeah, and looks thickened. Do we need to measure the thickness of pleural line, or
No,
just by the
no.
observation we need to
It's
comment?
it's the morphology you're commenting on. I mean, theoretically, what I'd say is a linear pleural line less than 5 millimeters is really what you want to see. And the pleural line looks continuous, thin, and regular, whether it's a 22-weeker, whether it's a 40-weeker, if the lung is well aerated. So we don't measure pleural line per se.
Okay, and here, can we say it is a whiteout lung?
Yes,
And there are a few subpleural consolidations with the whiteout lung. So
yes,
this I'll score it as 3 if we start scoring for the
that's correct.
RDS.
That's correct.
And this, Dr. Alok, this in this first picture will score it as 2 because it is not a whiteout lung.
My
This
gut
will be
feeling is
2 or
my gut feeling is if you zoomed out and
okay,
you might find that this is, for me, I would score it as a 3. I probably, if you
3.
zoomed out, you'd have a whiteout completely. Yeah, I'd probably
Okay.
score this as a 3.
And this is again 3. That was R1, this is
Yeah,
R2.
yep,
And this is the lateral area, right side.
yep,
R3, R4.
yep,
And this is again a similar picture of AIS.
yep,
Pleural sliding is present and with subpleural consolidation and AIS of AIS pattern.
yep.
And
Once
again,
you
we'll score it at 3. Like
this will be a 2,
2.
I would say.
2.
So the difference between the first image is you're starting to see a lung atelectasis. Once you can start seeing lung atelectasis, so
Okay.
more of kind of a loss of pleural line, the score should go up. And this is just for everybody. When you're scoring RDS, we know that the 0 is kind of the A profile. The 1 is kind of the A, B, dominant B. So more than 3 B lines per intercostal space, subpleural consolidations. Once you start seeing a whiteout, like you see over here, it scores a 2. But if you start seeing an element of atelectasis, and if you go back to the previous image,
This one first.
yeah, this one here, I'm just a little bit concerned that especially this region, you're starting to see atelectasis now. So just this is, it's R1 anterior. The probe should be perpendicular zoom out. And I think once you start seeing atelectasis, and if you zoomed out and we had a slightly wider kind of a vision, I'm sure you'd see more atelectasis. So this kind of just hits 3 for me at this stage, especially this region over
This will be
here.
3. This is
This would be a 2 for me. But
yeah,
here,
this is the third.
yeah,
And this is L1.
yep, yep.
And,
Can you see the atelectasis? Can you see? It's
yes.
beautiful.
So if you want to describe it as, can we describe it as bronchograms? Like a no.
So what you've got is, it's a beautiful image. The baby is basically easy on the ventilator at the moment.
Yes, yes,
Yeah.
yeah.
So you have inspiration, expiration. So when air goes in, when the inspiratory phase, the pleural line gets established. So pleural line established. And then when he expires, you basically have atelectasis. So what is happening is that you have these static air bronchograms of air that remain trapped when there's atelectasis. So these technically are subpleural consolidations in this region here. But really what you see here, these are static air bronchograms. And it's just when lung is atelectatic and falling away because of expiration, they're fairly decent sized static air bronchograms. Uh, Again, no
So
fractal
that was,
sign.
yeah, no fact. Let's score it as 3
I
because
would
there
score
is
it as a 3 because you have
atelectasis.
atelectasis. Once you start seeing atelectasis, and as I discussed with you, clinical correlation is important. I mean, this baby sounds like you had to tube him right at birth. And my gut feeling is he hasn't had surfactant yet while you've done the ultrasound, or has he?
It was not given. We'd given
Yeah,
after that.
yeah. So, again, what I'd say is, for me, I would use the higher score. I would always use the higher score in those circumstances.
This is again another region, VL2.
Yep,
There's a similar picture with subpleural consolidation
yep,
and a B profile.
yep. But less atelectasis. Again, lots of static air bronchograms with a pleural line that's established.
Yeah. Right. In this case, this is a case of RDS. Like we
No
have
doubt.
almost scored it.
Yeah.
The scoring is, I think, if we just, I think almost 15 or 16. Yes.
Yep. So did you give him surfactant?
Yeah, we had given surfactant as well.
Lovely.
So
Did you
that-
do an ultrasound after?
Yeah, I usually do, but I don't have pictures of ultrasound for this baby.
No
So I
problems.
had done on Feb
Sure.
12th.
So does anybody have any questions about RDS and scoring?
Seven.
Okay. You have one more case, Dr. Surjit?
Yeah, I'm just presenting.
It's a
17.
beautiful
can
case.
I
Yeah,
can I ask a question or
please.
make a comment while next case is being loaded? It's
Yeah,
Satish.
please. Yeah, go for it.
In beautiful images, Surjit. Those areas where we saw, is it okay to describe them as a snowflake appearance or?
Yes, yes. Yeah.
Yeah.
So Dr. Leo would classically describe it as a snowflake appearance. And what I'd say is that once you start seeing atelectasis of that nature, then the snowflake appearance has kind of disappeared. So it's really, the classical description is of subpleural consolidations with static air bronchograms, but with a pleural line that you can visibly see. So the grade that he gives to snowflake appearance, because for the ground glass appearance, it's usually still an A profile, but you really tend, from our perspective, to describe it in a more severe form of RDS. So, yeah, you're right.
Thank you, Alok.
My pleasure.
Yeah, should I start with another case?
Dr. Bhavinseva, you have a question?
Yes.
Please.
It's not about lung ultrasound, but tell me, please, in your practice, how often do you use a real recruitment maneuver with a very high level of PEEP, down for
Yeah.
12, 14 centimeters?
So what I'd say is that personally, my personal practice depends on the stage at which the baby is in its journey with lung disease. So a good example that I'll give you, if I've got a preterm baby, say 23 to 25 weeks, who has had surfactant and is not saturating, and I'm worried that the lung looks atelectatic because I'm moving, and if you look at me, I'll just turn my video on. So really, I would be doing a scan from anterior, lateral to posterior. And if I do it posteriorly and I kind of feel that the posterior lung is atelectatic, then for me, recruitment maneuvers would always be in slow steps early on, because the risk is, and this is really important, is the anterior areas of the lung in a supine position with surfactant, and the right lung, even if you have a tube in good position, tends to aerate better. Now, the risk of putting your PEEP up from 6 to 12 in that situation where a baby's very early on is you probably end up with lung recruitment quite rapidly, but there's a very high risk of having a pneumothorax. And I'd say that if I contrast that with a baby who has chronic lung disease, who, say, for example, is bigger, and I have a similar kind of appearance with a baby who is moving towards steroids, because the lung is, I would say, more solid, less well aerated, and there's chronic involvement. That is a baby who might tolerate this kind of recruitment maneuver better. The open lung strategy, as described by colleagues, usually involves the lung ultrasound being kept at a specific area, and that's in the area where you find most atelectasis. And you really increase the PIP or PEEP. It's up to you. I would usually increase the PEEP in situations like this in increments of 1 to 2, depending on where I am. If I'm 5, I'd go up to 7. I might go up to 9. I'd rarely use a PEEP above 10 in situations like this, unless the baby is much older. Older babies, we commonly use PEEPs up to 12. But I don't use PEEPs higher than that. I know some of my colleagues across in the North Atlantic and in Canada do. My only comment is just be aware of the heart-lung interaction, especially again early on in the first few days of life. If you increase PEEP that much, you might really decrease venous return. And if that is the case, then you'll really make saturations much worse because the heart is not actually getting enough blood to perfuse the lungs. So for me, gentle and slow in the early stages has always been a better approach. We've got a whole session on it, which kind of describes what the open lung strategy is, but also what patterns you see. There's a pattern that's been described with atelectatic lung for recruitment, just called an S pattern. And really, what you're trying to do is if you have atelectatic lung that you're recruiting, you keep your probe there, you keep watching, and you go up by increments of PEEPs of 2 or a PIP by 2. And really, what I do is I wait about 3 to 5 minutes to try and see if I can actually see the pleural line getting established. And if I can see the pleural line getting established and my baby's getting better, I would wait. Some people basically want the entire lung open. The danger with that is, my only comment is the areas of the lung anteriorly which are well recruited. Can you imagine what you might be doing to them in terms of damage? So I'd say use it cautiously. Be very, very, I would say, aware that if you're using it, the baby who's older with chronic lung disease and atelectasis, or I would say with meconium aspiration and atelectasis, the term baby will tolerate it much better than the preterm baby. So while you're learning, I would say for extremely preterm babies, be very careful. I have seen some really, really bad pneumothoraces with open lung strategy, and points where babies deteriorate so quickly that you can lose them very quickly. So early days, I wouldn't recommend going up by PEEPs to 12 to 14. Uh, you know, it's a recipe
Thank
for
you.
disaster, but that's just my opinion. Go
Thank
for it,
you.
Surjit. You can share your second case.
Yeah. Can you see my slide?
I can see your old presentation.
No, this is a new one.
Okay, this is a new one. Go for it. Yeah,
Yeah, I just thought there was another case of a preterm baby, and I actually needed some suggestion also
sure.
for this case. This baby was born just last night.
So I'm
It's a
sure,
28.
Surjit, we can see your old case. I don't
Okay.
think we're seeing your new case at the moment.
Okay.
Stop your share. Just you can stop share. Well done. So just while Surjit is working out, Dr. Ashraf, do you want to share your slides?
It is visible?
Yeah, it's visible. Yeah.
Okay. Good evening, everyone. Today I will discuss neonatal pulmonary atelectasis. This is 12 days old extreme premature baby, 24 week. Nowadays this is for 24 week, 24 days and 27 BMA. It has birth weight 650 gram. Delivered by normal vaginal delivery. Mother 24 years old. Received 2 doses of dexamethasone. Upper 7 and 8. 1 dose of surfactant 90 minutes after delivery. It put in the BCAC mode with volume guarantee. cranial ultrasound done the first day with grade 1 in intracranial hemorrhage, وابلاي نيوتال كير باندل اي في اتش بريفنشال باندل والكليبس باندل والفاب والنيك باندل. ستارت على التي بي ان والفيكلوزول بروفلاكسيس والانتيبيوتيك والستارت اي بي ام تروفيك فيدنج. Now he reached the feeding now with 13 ml every 3 hours. Every 3 hours. As the day of 11 days old, he suddenly decompensated. The saturation on in NIV go to down to 60 and 70 on bradycardia. Intubated with all the third lung ultrasound to look for the causes as the part of the crushed baby syndrome, crushed baby. This is the first X-ray on admission. When this is ultrasound, you know this is RDS. After 3 days, the lung is beautiful. As the day of the collapse, you have this is the X-ray and this is the issue. Now in the right lung, in the R1 or R2, it is white lung with broken pleural line with subpleural consolidation. In R3, we have CBP profile. We have here a lot of deep atelectasis with broken pleural line with no sliding. In the right, in the R5 or R6, we have C profile. There is no pleural line that is broken, no lung sliding. We have a big area of atelectasis. Sometimes called the sun ray line. If you check like here, it is like sun ray or cloud. If you find this, it means the lung is recruitable. We big sign, no rib shadowing, abnormal pleural line, thick and irregular, interrupted, and absent in R3 and 5 with no lung sliding with B profile subpleural consolidation. In R1, in C profile in with static bronchogram, in R3, 4, 5, and 6. في lung pulse here. R5 6 في C line, sun line, these lines, multiple lines. The same issue in the left lung, the same profile, C profile with line. This time it was I intubated them. I make recruitment. This is 1 hour after recruitment. Now بقى في visible pleural line وفي some aerations. Here pleural line not broken. When start to be aerated lung and transfer to be profile. After 24 hours, more improvement. What I did at this time, I increased the BIP to 24 and the beep to 7. After I check that at the same time I'll make scanning. Once I found the baby started to recruit, I decrease one by one till reach to the 20 and offer 5.5. So this is atelectasis. This is after 24 hours. The criteria of atelectasis is absent pleural line, no lung sliding, absent absent A and B line, C profile, tissue-like sign, static bronchogram, sometimes dynamic, no shred sign, large concentration with clear border, where sometimes lung pulse. Thank you.
That's a beautiful case and a very good example of use of lung ultrasound for kind of lung recruitment. Again, just giving everybody a flavor. I mean, the advantage of you intubate, you do a chest X-ray, you put the baby on the ventilator, you then repeat gases which get better. But sometimes babies will not get better. You might get recruitment where your CO2 is improved slightly, but you're not being able to oxygenate because babies still have significantly atelectatic lung. And in particular, if they're kind of sedated and paralyzed and they're persistently supine, you haven't prone them, you're not moving them, the posterior areas of the lung become atelectatic. And this is a beautiful example again of how many x-rays are you going to do to try and demonstrate good recruitment of the lung, because eventually a lot of these x-rays will actually show that you have 8 posterior spaces, but actually what they don't demonstrate to you is the posterior atelectasis that you see in the lung, which is very, very well demonstrated by lung ultrasound. So again, a really nice example of using the recruitment strategy. So the sunray phenomenon that Dr. Ashraf described comes from a study which is called the Luster study. It's a it's basically important because there's elements of lung that sometimes are so atelectatic and unrecruitable that actually a recruitment maneuver will not work. Now, to give you an example, a simple example might be a situation where you've got the tube down the right main bronchus, and your left lung is completely atelectatic. Now, if your tube is down the right main bronchus, so I'm just gonna draw it out on the slides over here. So if this is your bronchial tree, your right main bronchus tends to be a little bit more horizontal as compared to the left bronchus. Now, if your tube is down the right main bronchus, what happens is it also blocks air entry into the left side. And what you get is a complete collapse of the left lung. Now, the problem is a recruitment maneuver over here will recruit right lung, actually cause overinflation, but will not recruit the left lung. Now, often the appearance you get when you do a lung ultrasound of this left lung is a very large area of global atelectasis with absolutely no aeration, no pleural sliding, but no sunray appearance. And that is a marker for you that actually really this might not be a recruitable lung. For me, if I have an appearance of either the right upper lobe going, or if I have the entire kind of lobe of the left side atelectatic, I always go back to my tube position. And it is something that is very common. I would recommend always that you go back to seeing where your tube position is. Uh, Dr. Ashraf, do you have any other cases?
Yes, please.
Please, please, we'd
I will stop share
love.
and give another one.
Sure,
Okay.
sure.
Sorry, can I ask about this case? Could you explain again what is a S line, sunshine lines? Yeah,
Dr. Ashraf, you can open the previous presentation again.
if it's not difficult.
Yes. Hmm. This is the one. This is the one.
It's not visible, Dr. Ashraf, at the moment.
Yeah, it is not visible.
No, I think you might not be sharing the screen.
Okay, I will. I will go out. Please, I will get it again. Please. Sorry. I lost. Yeah, just a minute, معلش. Now visible? Now it's visible now?
Yes, we can see. The
Okay,
first
I will
slide.
make I will make it share. So what happened? Oh, what happened? Is it okay now? Is it okay now?
Yes. Could you demonstrate a C line again, please?
Yes, this is okay.
And explain what is it.
Dr. Alec, you can explain or can I go on? Dr. Alec, you hear me?
Hello, can you hear?
If it is a lung, yes. You see these lines, this is all atelectatic.
It's like a bronchograms, that? It's a signs of bronchograms.
This is a static bronchogram. But if you found here, you say like cloud, like this. Imagine, yes, it's like cloud. Feel something ray down coming down from the this area. Look for this area.
So can you see the linear pattern? There's a linear pattern
Yes.
that comes through. Those linear patterns that you see, Dr. Babin Seva, and I've got another image that I'll share with you, are like the rays of a sun. So if you look at my fingers, they're going in and out like that. So they tend to be horizontal. So if I just draw it out for the exact areas, can you see this area here, this area here, this area here? Yeah. So they're like the rays of a sun. So once uh, Dr. Ashraf is, I've got an image here that I can show you which demonstrates it very nicely. This is, it's a very good image. Often in neonates, it's a little bit tricky to kind of delineate it because you've got massive atelectasis here. But actually these linear regions that you see, they are like the rays of the sun coming out. And that's what they call S-line pattern.
Okay. Thank you.
Or in any other condition also?
No, it's usually a marker of recruitable lung. So if Dr. Ashraf, just while you, I'm just going to share my screen. That'll stop
Yeah,
yours.
I will stop. Yeah.
Can you see my screen?
Yes.
So if you look at C, can you see C?
Yes. Yeah.
So in the C pattern, can you see these horizontal lines? These are like the rays of a sun. And this is basically classically what it's called, the sun ray pattern. Now, when you look at it, you have no pleural line at the top. So I'm just going to annotate so that you can see. So there's no pleura here that's visible. This is because there's no aerated lung. These are basically static air bronchograms that you see over here. But can you see these linear shadows? They are like rays of the sun. And this is typically what is called the S pattern. When you recruit them, when you recruit this, naturally there'll be aeration, and these areas of brightness, which actually represent trapped air, they will disappear completely. But if you look at D, can you see any linear pattern? You cannot see any linear
No.
pattern there. Now, this is a very large area of de-recruited lung. And really, this de-recruitment might be because you have what you've got here is you've got consolidations over here. And just deep to this consolidation, you've got atelectasis. There's no pleural line established. Now, the question is this mnemonic? You have consolidation with exudate to the point where this area is not aerated at all. Now, if you have a lot of exudate in this region, you might not be able to recruit this area of lung because no matter how much pressure you put in, you're not going to get this lung aerated. What you will need to aerate this lung is physiotherapy. You will have to knock this lung so that you can get the exudate out of these regions. And when you knock this lung with percussion or therapy, then you might find that these exudative areas that have blocked, caused non-aeration of this lung become open, and you're able to get air into this tissue. Now, this is just for your knowledge. This is not an absolute marker. It's been demonstrated in only one study, which is called the Luster study. Again, we will be talking a lot about this. I'll be showing you cases of recruitment where we have seen the S pattern disappear, but there are cases where it doesn't disappear at all. And really, what I'd say is in the cases that it doesn't disappear in, you really need to think of alternative ways of trying to open that lung up, not just pressure. And the reason I'm mentioning that is because there might be areas of normal lung that you will massively overdistend. And I have seen a baby where we've tried to recruit, where basically what's happened is the normal lung has popped. So just again, I would advise caution in how you approach this. Usually what people say is it's increments in PEEP of 1 to 2. Over, I would say, a period of a few minutes, looking, keeping your probe there and looking. And if you find that there's absolutely no recruitment in that region, then be wary. If you've gone up by a PEEP of 4 and you see no recruitment, whether you have an S pattern or not, that might not be a recruitable lung. Alternatively, there are sometimes areas of, I would say, atelectasis that don't have an S pattern which recruit as well. So it's not pathognomonic is the word I would use. I think your clinical judgment, clinical improvement of the baby is very important. And just be aware, you cannot diagnose over distension of the normal lung using a lung ultrasound. So be careful, because if you increase your pressure too much to increase and recruit lung, you might actually paradoxically reduce venous return. If your baby is not improving with these maneuvers, again, heart lung interaction, there's a whole lecture on it, which Nadia will cover. I think it's really important to kind of make sure that you're not compromising your venous return. Does that make sense?
Yes.
God bless you. Dr. Ashraf, you can share. I will stop my share.
Yeah, thank you.
Go for it. Any questions while Dr. Ashraf is uploading his presentation? Any other questions? Surjit, is your presentation ready?
Okay.
Oh, okay.
Is this
Dr.
visible now?
It's not.
Yeah,
No.
yeah, it's ready.
Uh, I think you're not sharing screen, Dr. Ashraf, at the moment.
Yeah, I'm sharing now. Visible now? Visible?
Yes, it's visible.
Okay. We're going today to present one case of RDS. This is the preterm female neonate, 33 week, emergency AS because antepartum hemorrhage from OT. The weight was the stress. Her weight 1.6 kg. It is just delivered yesterday 8 p.m. The mother have history of preterm delivery at 31 week, and the baby died at 45 days. When admitted in the unit, it put in the nasal bubble CPAP, initially stable, and the SpO2 in the target range, 2.3. By time, start to be needed more oxygen to reach the target and increase the risk of work of breathing. Initial CPG, it was pH 7.14, CO2 55, LO2 46, basic excess 12, lactic acid 9. Lung ultrasound done 11 hours after admission. This is the X-ray, reticulation, diffuse reticulation in pattern. This is the lung ultrasound. This is what I get. In R1, it is irregular pleural line with subpolar consolidation here. and R5 و6 also في ground glass appearance with compact B line here and here. There is no rib shadow, and also an R3. The same in the left lung. We found this is irregular pleural line with thick وفي subpleural consolidation micro consolidation. There's no rib shadow, but still the pleural line more better than the previous image. And في AIS compact B line is a homogeneous disease in bilateral. So I make a lung ultrasound score. It's within the L1 and 2. It is 2 by 2, it is 4. In left lateral, it was 2, it was total 6. The same in the right lung. It's a total score 12. I give one dose of Cervanta by laser technique.
Beautiful images, Dr. Ashraf.
Yeah, this is AIS. This is the twin sign. This is a rib with the rib shadow. By more condensed B line, it will be absent. Rib shadow not appear. And
Yep.
this is alpha edema fluid there.
Yeah.
With tiny micro with a thick border line.
So if we just go to your previous slide, Dr. Ashraf, Satish
Okay.
had asked what the snowflake sign. So
This one?
no,
No.
the one before this.
This one?
Yeah.
Well, this one.
So it's got a very mild snowflake appearance there, but it's actually this image here, this region. This is classical snowflake sign for you. Very mild.
Yeah.
You can see the snowflakes
This
there.
this goes with the ground grass appearance.
Yes. There are grades of snowflake sign that have been described by Pang et al. In their article. Again, something that I will cover with you on Sunday. But we'll talk about the severity of RDS and how we classify that on lung ultrasound. But this is a mild snowflake sign, and it would not be unusual for us to see a ground glass appearance on chest X-ray with this. Very nice images, Dr. Ashraf.
Really, before I go today at 4 o'clock, I did another lung ultrasound because I give Servant at 10 o'clock.
Yeah,
It is much better. Still much rated borderline. It was much better than this, but still have B lines, but less than this imaging.
sure. Lovely. Thank you so much.
Thank you.
Is that your last case?
Yeah, I made two cases, one
Lovely.
text and one.
Beautiful.
If
Very
you
good.
have another one, I can get a share now. Now I have a lot, no problem.
No
If you
problem.
have time.
So we'll see Dr. Surjit's case today.
Yeah,
Thank you so
I'm
much.
sure.
God bless you. So your screen is visible, Dr. Surjit. Yeah.
Yeah. Can you hear me?
I can hear you as well. Yeah.
Yeah, this is a baby born just last night. Is a 28 weeker, 1.2 kg.
So your
Had
slideshow is not visible.
okay.
I think you're sharing your screen.
How is it now, Dr. Alok?
I can still just see your screen. You might have to stop share,
Okay.
open your slideshow. When you share screen, you're looking for your slideshow, not for your desktop. Very nice. Yes. Now just go to full screen. Beautiful. Carry on.
Okay.
That's beautiful.
Yeah, so this baby was born last night, and baby had distress, so we had put the baby on CPAP, and the oxygen requirement was 30%. So otherwise, today afternoon, the baby was stable with 30% FiO2 on bubble CPAP. But I just wanted to do a lung ultrasound. So at 17 hours of life, I did a lung ultrasound, and these were the views today afternoon at 17 hours. So this is R1, and I somehow couldn't have a proper alignment. I don't know why I was not getting a horizontal pleural line. And this pleural sliding is there, but again, the pleural line is, it looks continuous, but it is irregular, what I feel, or maybe because of the subpleural consolidations, I'm able to see it like that. And there's a white out lung.
That's
Um,
correct. Again, the reason you feel the pleura is that way is because you've zoomed in quite a lot. You need to zoom out and have a depth of about 3.5. But yeah, you can just see
okay.
again, this is a snowflake appearance on the left side over here.
This is,
Yeah. And the pleural line basically
okay.
is better established here, naturally, because maybe this area has worse surfactant deficiency and hyaline membrane disease. But yeah, you're right. Very
So this
nice.
I'll score it as 3 in R1.
Uh, yeah, between 2 and 3. 2, I'd probably say. I'm not clinically convinced you have a lot of atelectasis there. You have a snowflake
Okay.
appearance with a kind of a whiteout. Yeah.
So this whiteout can be seen in 2 also, in score 2.
Yeah.
So there need to be a
And
atelectasis for
so
to say it as
that's
3.
why some people have actually introduced a scoring system with 5 categories uh,
Okay.
to try and make it more sensitive. But I
Okay.
wouldn't worry, because if that's what you can see everywhere, your score will hit uh, more than 9 easily. So don't feel too stressed about confusing 2 and
Okay.
3. Yeah.
Okay. And this is what I could see in R2.
Yeah.
It is similar picture, but I was wondering why this area is showing me as a profile.
Beautiful. So first of all, this is a very nice kind of example of, you just need to make sure that that area is not air. Some babies will have small pneumothoraces with RDS, especially in the period where they've not had surfactant. For
Okay.
me, the giveaway when I look at it that this is not a pneumothorax is, I can see these comet tails here that are moving.
Comments.
This is
Yeah,
just a
yeah.
double lung point.
Right.
There's just better aeration.
Okay.
And this basically reflects the fact that this is more surfactant deficient as compared to this region over here. Now, just remind me, is this baby intubated?
No, it's on CPAP.
It's on CPAP. And you haven't done Lisa yet.
No, no, I had not done
Okay.
at that
So
time.
this is just
And I've not given yet because of some.
yeah, it's just an area that's better recruited. And usually what I'd say is the right anterior areas tend to recruit a little bit better as compared to the posterior areas if the baby is supine. So I would still be
Should we call
worried.
it as a double lung point, or
Yes,
like
you can.
should we
You can
take
call
this
it a double
picture
lung
as a
point.
TTN or?
No, so this is the important thing. The double lung point is not pathognomonic of TTN alone. And you need to look comprehensively at all your regions. And if you can see subpleural consolidations and a clinical picture that, kind of fits with, if this is an unsteroided boy who's on CPAP and 45% oxygen, then really for me, I feel that there are subpleural consolidations. To get them a little bit better, the sonocyte has sharp mode, so you can actually go to sharp mode and that'll demonstrate them better. But there's absolutely no doubt in my mind that when I look at the right side of the screen over here, the definite subpleural consolidation is visible. And again, I think if you kind of look at this region, there are some subpleural consolidations that are visible that are coming in there as well. So for me at the moment, even with a double lung point, I'd class this as RDS.
Okay.
Yeah.
Dr. Alok, please.
Yes,
It
please.
is strange to find all lung B profile with one sector A profile.
It is
Should I have
unusual.
to M mode? Maybe
I
it's
would M mode it. Absolutely no doubt I'd M mode it. Because you really want to make sure that's not what is called a bubble or an anterior pneumothorax in that region. I think for me, I can see some comet tails that move. So I'm clinically convinced they're sliding. So I think that's a
But
double lung
if
point.
you look, yeah, if you are looking good, yeah, maybe there's no sliding because this way you have sliding over it, no shrimming of the border line. It is a small area, yeah, and it's difficult to all lung, white lung with small areas irritated.
You're right. M mode would help us confirm. Did you do an M mode?
No, I haven't. I have not done.
You
Not done.
must do M modes, Dr. Srijit. It's quite
Yeah.
crucial. So the the anterolateral scans, your standard scan should have all your regions R1, R2, R3, R4. If you're doing antelo, they all should have M mode.
And this is R3, R4, and I didn't get a B profile there.
Yeah, and I
And
don't have subpleural consolidations. This is the
yeah, this is,
importance of really, from my perspective, doing a comprehensive scan now, because for me, there's a lung spared region, but definite subpleural consolidations in the previous image and this next image. Here, I can't see them.
yeah, this is a right lateral,
Yep,
R3, R4.
yep.
So what we usually think RDS is a homogeneous disease. So like I was wondering, in the lateral area, there is no B
But this is
profile.
a 32 weeker. This is not a
This is
25
28
week,
week,
28
28
weeker.
week.
Okay. So, and steroids received?
No, not received.
Okay.
This is L1.
This for me wouldn't be TTN. You've got a snowflake
Or maybe
appearance with the eyes.
surfactant in the right side.
No, that's why I asked whether the babies receive surfactant, because this is the pattern of aeration after surfactant is what you would see, uh, especially if surfactant's gone down the right main bronchus, but they haven't given surfactant yet.
So this is L1 again. There is irregularity of the pleural line with
Yep.
subpleural consolidation.
No doubt about it.
And
Yeah.
again, is this the snowflake sign?
Yeah.
And a B profile, like white out lung.
Yep.
Yeah. This is L2, a similar picture.
Yeah.
And this is left side lateral area.
Yep.
And the posterior also I had B profile, similar picture, but in the lateral areas I didn't have B profile. It was A profile there.
Sure. In terms of your gas exchange, I'm just curious. I mean, what was your CO2 and your pH?
The pH was okay. It was around 1.34 something, and the CO2 was around 40.
So it's not
And the
bad.
baby was
I mean,
yeah.
my only comment is mild RDS will have areas of lung sparing. There will be areas of aeration of the lung. And again, the real question that you're asking is, this is your first lung ultrasound.
Yes.
If you kind of had done this a little bit earlier, under 2 hours, and you're getting this appearance at 3 hours, and this is better aeration, and your baby's getting clinically better, then really the
Yes.
question from your perspective is whether this is just mild respiratory distress syndrome as opposed to moderate to severe, and whether this is improving. Because the natural history of RDS, a lot of babies at between 28 and 30 weeks, in the COIN trial, more than 50% got away without surfactant. So they will have a natural course of evolution where RDS evolves into aerated lung. I'd be curious to
Actually, I was
know
wondering.
what you
I was
did.
wondering if surfactant, because the baby is otherwise stable on CPAP, FiO2 is 30%. I actually suggested them I thought of giving surfactant, but till now the patients, there's some affordability issue and we have not been able to give surfactant till
And the
now.
baby's better?
And baby is doing fine.
Yeah, that's what
But I actually suggested for surfactant. I thought because there is whiteout lungs in on both the sides. So
Yeah.
I thought that I should give surfactant.
So what I'd say is look at your whole scan. I would be doing a comprehensive scan. I'd go to the posterior regions in this as well. And really, clinically, the feel I'm getting is you have a lot of lung spared areas with decent aeration. If you're just in 30% FiO2 over 28 weeks with a CO2 of 40, there's time to wait and see, which is what has happened in this case. My overall feeling is I think this is probably mild RDS. This is definitely not TTN. You've got a snowflake appearance over here. And I think
Yeah.
your baby is getting better. Now, just for everybody, it's important for us to understand that a lot of babies will have fluid in the lung right at the start and will go on to develop hyaline membrane disease uh, with time. So you may, if you do a very early scan, see just interstitial edema, whiteout kind of an appearance without the subpleural consolidations which evolve. At the same time, you might have fluid that resolves, and as the fluid resolves, subpleural consolidations are visible with areas that are lung spared. So it's really important that you know that the double lung point is not pathognomonic of TTN. It can be seen in a variety of different conditions, and that's why clinical correlation is quite crucial. Did you score this baby by any chance? I'm just curious.
Um, yes, it was like um, just
It's a nice case. It's a very nice case.
so this I'll take it as 3. So
Yeah, I'd probably say
two.
2. I'm not
2.
convinced you have clinical atelectasis.
Okay. So this is also 2. So it's
Yeah,
4.
yeah,
This will be 0.
yeah,
Yeah. So it's 4, and again this is 2.
yeah,
This is 6, and this is again 2. So it's 8.
yeah,
This I think we can take it as 1.
yeah.
Mm.
So you're
So
at the
the score
cusp
would
of
be
it, a
9.
9. And what I'd
9.
say is that, again, I don't think it would be unusual for somebody to have given this baby surfactant, either
Yeah.
insured if the baby has good efforts or Lisa the baby versus not. Uh, I don't think it's, I would say, without remit to say that you could have waited as well and done another lung ultrasound, maybe an hour later. And again, if the lung ultrasound score is deteriorating, you have worse clinical appearance uh, because the baby's FiO2 is rising, then you bail out. So again, what I'd say is that there's always the remit of doing serial lung ultrasound. Does anybody have any questions on this case? It's a very nice case. I think one of the messages I'd say is please try to do M mode. I think Dr. Ashraf is right that what you don't want to miss is a small pneumothorax which is gradually getting worse. And we get a lot of babies with small areas of anterior pneumothorax bubbles, especially near the mediastinal edge on the right and left sides. So, you know, very nice cases if I summarize today. Well done. I am going to kind of stop here because I think we're kind of 190 minutes soon. So well done, guys. Really nice cases for us to see. On Sunday, what we will be doing is we will be doing a workshop again, focusing predominantly on RDS, its severity, specifically looking at cases and the approach to LISA. What I would like to kind of highlight is again how you approach surfactant replacement with clinical correlation, but also for babies who are intubated. The question then is how you might want to interpret serial lung ultrasounds to determine your second dose of surfactant. So for those of you who are there, please do join us. And thank you, everyone. Beautiful cases.
Thank you.
Thank you.
Have a good day. God bless you.
Thank you. Thank you.